Hello, Ashanti. Thank you for joining. Hello, everyone. My name is Danny. I'll be your host for part of this webinar. Dr. Hughes is with us, so thank you for joining. I see more people joining, so we're just going to give them a few minutes. So let me put myself on mute. Very soon we'll get started. Hi, Sherry. Thank you for joining. Today, the topic of this webinar has to do with uterine fibroids, and we're going to talk about that at a very high level, but also if you have any questions, please feel free to leave them in the chat. Heather, Kim, Christelle, Sherry, thank you for taking the time this evening. Dr. Hughes is with us, and we're going to address any questions that you have, and she's also going to talk about the uterine fibroid and treatment options and things of that nature. So thank you for taking the time. All right, I want to make sure that technology is cooperating, so I'm going to send everybody a little message. If you get it, let me know if the sound is good. So it's 6 on the dot. Thank you for being so prompt. Most people join within the first 5 minutes. We'll wait at least a couple minutes before we actually get started. Also with us is Monica. Monica will be assisting if you guys have also any questions, or if any questions about scheduling an appointment, if you need a one-on-one consultation, questions about insurance, anything at all that has to do with that, she can help, and she's with us as well. All right, hello, April. We got more people joining, so thank you for that. All right, so it's about 6:02, so we'll get started. So if you see, all right, so just wanted to, before I pass the baton over to Dr. Hughes, just wanted to introduce her a little bit. So if you're on this webinar, you probably saw an advertisement on Facebook, or maybe you found us on Google and you heard about this webinar. Dr. Hughes is a board-certified vascular and interventional radiologist, more than 20 years experience. She received her degree from Boston University. She completed her radiology residency at Beth Israel Deaconess Medical Center, as well as Harvard Medical School. She served as chief resident at Harvard. She's a native of Boston. She came to South Florida in 1997. While here, she completed her vascular and interventional radiology fellowship at Baptist Cardiac and Vascular Institute. In 1998, she was hired to develop the Interventional Radiology Department at Holy Cross Hospital in Fort Lauderdale. So you guys are probably all wondering what exactly is interventional radiology. So that is the first question that we actually have today from somebody that left that question. But first, I'm going to allow Dr. Hughes to introduce herself. I'm going to stop sharing my screen. So Dr. Hughes, how are you feeling this evening?
Hey, good evening. Thanks, Danny. Thanks for setting everything up, and welcome everybody. We usually do these on a Thursday evening, and I think with the holiday dates got switched around. So it's, as somebody was saying earlier, it's hump day. So thanks for spending hump evening with us. So hopefully this will be an educational hour for you folks. So Danny, I think you were saying that, and it's funny that you're asking in terms of the definition of an interventional radiologist. And I actually, before getting on this webinar, actually was doing a consult with a young lady, and again saying that it's, I guess with what we do, we work with a lot of specialties, including obviously gynecologists. But for what we do, your average patient doesn't say, "Gee, I have a compression fracture. Let me go see a radiologist," or "Gee, I have fibroids. Let me go see a radiologist." So we are specialists. Danny had mentioned we're obviously physicians. We are trained as diagnostic radiologists in terms of reading and interpreting X-rays and CAT scans and MRIs and ultrasounds, but we do additional training, basically using imaging to guide us in terms of our procedures. So that typically compared with surgeons and surgery, our incisions tend to be a lot smaller. Oftentimes it's just the size of my pinky nail, but it's a Band-Aid afterwards. They're not big incisions. Typically our procedures are done under a twilight sedation and don't require general anesthesia, shorter recovery time. And the insurance companies love the fact that our procedures tend to be less expensive, and patients are usually back to work in their activities in shorter order than if they had traditional surgery. So we literally do things from head to toe in terms of taking care of patients with interventional radiology. But tonight we're obviously going to focus on one subset, one problem, that being women who are suffering with fibroids.
Okay, great. Thank you for that. And I see some questions in the chat. We have other questions as well, so we're going to have other people also asking them.
Okay.
Actually, there's one in the chat that that I think is also very pertinent. So, and Monica, I know you have also, so I'll let you take over after this one. But the first question that I have is related to the hysterectomy. And the question that they have is a hysterectomy the best option for me? I've been suffering from uterine fibroids for many years, and I was told this is the only and best option.
Okay, that's kind of a loaded question, but it's one that I think women are faced with commonly. And probably just in terms of a little backdrop before we get into specific treatments, including hysterectomy, I think obviously anyone who's on this chat tonight or the webinar is familiar with what a fibroid is. But just by way of background, which makes it, I think, a little easier to understand some of the options that are out there. Notice I'm saying options as in plural, as in hysterectomy is not most of the time the only option. But fibroids are benign tumors or benign growths that occur on the wall of the uterus, and that they're extremely common. And literature says that 1 out of 3 women over 35 has fibroids, and 1 out of 2 Black women of Caribbean descent have fibroids. We're not sure what the connection is, if it's genetic, environmental. We're not sure what the how that plays in as a risk factor or a characteristic. But that being said, extremely common. They're not cancer, they're not precancer. So typically, if they're not bothering you, you don't need to have treatment. But if you are suffering from symptoms, and I'm sure that probably most of the women who are on this webinar tonight are unfortunately suffering from symptoms, whether it be heavy bleeding, anemia, passing clots, cramping, some of what we call the bulk symptoms, if they're big and bulky and bulgy and they're pushing on the bladder or pushing on your back or on the rectum, that women tend to have a lot of symptoms in terms of pain or discomfort. Never mind the anemia that can go along with the heavy bleeding. So I think that being said, hysterectomy is not the only option in the majority of women. There are a small percentage of women that, based on either their medical history or particular allergies or the anatomy of the uterus, that may be the only or best option. But I would have to say it probably is less than 5% of patients. So I think that without knowing the specifics of your case, if it's something that you're local and that you'd like me to take a look at your imaging and sit down with you in terms of your history and so forth, I'd be happy to do that. But for the most part, if I were to make a blanket statement, I would say that majority of women, hysterectomy is an option, but it is not always the only option. So that probably, would dovetail into, okay, then Dr. Hughes, what are the options? And I think that in this day and age, obviously, we're on a webinar now between access to the internet and second opinions and Instagrams and webinars and Google searches and talking to friends and colleagues and physicians, as well as family members, there's lots of things out there that people talk about that work for treating fibroids. And I do caution you, I guess with anything, there's lots of stuff out there. And some of it's accurate information and some of it's not necessarily accurate information. But in terms of the fibroids, every year there's something that's sort of sexy, the in vogue thing. One year it was turmeric, another year it was an Indian red clay, another year it was a Chinese herbal tea. So every year there's something that sort of comes and goes that you read about in Vogue or Self or wellness magazines. But in terms of what we have medically and scientifically, there are 4 things, and I'll touch on each of those briefly. 2 things that I tell patients that are available and out there in the community, that I think be aware of it for the purposes of informed consent, but I wouldn't waste your time or your money on these 2 procedures. The first one, and the terms can be confusing. The first one, I think, just to be aware of what's out there, is something called an endometrial ablation. And that's an office procedure that a GYN does, where they take a little catheter, almost like IV tubing with a balloon on the end of it, and they go through the cervix, through the vagina, through the cervix, and they inflate this balloon in the cavity and inflate it with a hot oil or hot water to burn the lining. So if your problem is in the lining, little tiny polyps or a benign thickening of the lining, that's an appropriate treatment. But fibroids start and grow in the wall of the uterus. So burning your lining, for the most part, isn't going to do anything to treat your fibroid symptoms. So I think be aware of that. If it's mentioned or brought up, I don't think that that's an appropriate treatment for fibroids. Second thing is something called HIFU, which is a high frequency ultrasound. And most people may be familiar with or know somebody, have heard of somebody that has kidney stones. And there's a treatment the urologists do where they blast or zap the stones with a high frequency, a lithotripsy, and that's a high frequency ultrasound. That can be used for other things. And there's been some research for over 20 years now using a high frequency probe under MRI guidance and pointing it at the fibroids and burning the tissue. But there's a reason why it's 20 years later and it's still considered research and experimental, because the data is not very good. I know we had a place in Boca, I think, that was doing it, but they went out of business. Insurance companies aren't paying for it. My society and the OBGYN society saying it's experimental. So again, I think be aware of it for informed consent, but neither one of those would I waste time with. So the 4 things that are sort of standard of care, and each of them have their pluses and minuses, including myoembolization, are hormones. The uterine fibroid embolization, or what we refer to as UFE, it's kind of a mouthful to say, myomectomy and hysterectomy. So hysterectomy, I think most women probably on this chat have either had that suggested to them or are aware of what it is. And that's a GYN surgically removing the uterus. Sometimes it can be done laparoscopically, but oftentimes in women with fibroids, if they're big and bulky, it ends up being an open surgery. So it's general anesthesia, it's a surgical incision, and typically it can be 6 to 8 weeks recovery time. So, and a lot of women, if they can avoid surgery, would prefer to do that and don't want to have to, lose their female organs. Taking a step down is a myomectomy, which some people refer to as a partial hysterectomy. And that is, again, the gynecologist going in and physically cutting out the fibroids, but leaving the uterus for the purposes of getting pregnant in the future. So if you are somebody that you're not planning on having any children or any more children, typically the hysterectomy is offered, not the myomectomy. Now, myomectomy was the standard of care for years before the UFE came along. But as UFE came along, the myomectomy got less popular and the embolization got more popular because it's less invasive and we actually have better results than the myomectomy. So, and the whole way came, I guess, so I'll talk about hormones. Hormones are a Band-Aid. What little we know about fibroids is that they can get bigger with pregnancy, they can get smaller with menopause. Different combinations of hormones can help mask the symptoms, but the problem is that they aren't a treatment or a cure. They basically are a Band-Aid to help with symptoms. And for the most part, I mean, some women, can get some relief from the bleeding and cramping with like a birth control, but for the most part, women have to be on a much stronger, higher dose of a hormone, and that's where they tend to run into side effects in terms of weight gain, acne, hot flashes, mood swings. Your blood overall gets thicker. You're more prone to forming clots. So most women, and again, I'm biased because I see the women either who don't want to do hormones or have taken hormones and didn't like the way they felt and felt that it didn't give them relief. So that's the least invasive. If somebody's anemic, I don't think the hormones are a good way to start because it potentially could take up to a year for the patient and the GYN to sort of work out a cocktail, if at all, it's going to help. And that's a problem being anemic that long. So obviously saving what I think is the best for last, which is the UFE or the uterine fibroid embolization. And embolization basically is the medical term for us putting something into the circulation to cut off the blood flow. It's been around for a number of years, and specifically, myself as well as other interventional radiologists have been doing it for probably close to, 25 years now, specifically for fibroids. And the whole way came about, sort of the principle behind it is, which I don't need to tell a lot of women who are with us on this webinar tonight, is the fibroids are very vascular, and they end up stealing or parasitizing little branches and creating their own blood supply from the uterine arteries. And it's sort of the chicken and the egg. The bigger the fibroid, the more blood flow, the more fibroids, until you do something to break the cycle. So embolization is a term where we put something into the circulation to cut off blood flow. And as I mentioned, we literally do it from head to toe. Certain aneurysms, the brain will embolize. Certain brain tumors or kidney tumors will embolize them before the surgeon operates to minimize bleeding. Trauma, if somebody stabbing or a laceration or a gunshot, or even, little old lady falling down the stairs and having internal bleeding, oftentimes trauma will ask us to find the bleeding blood vessels and to plug it up. Women who would bleed if they have a baby, they'll ask us to come to the OR and embolize the uterine arteries. The whole way it came about for fibroids is there were certain gynecologists over the years who used to ask us to embolize the uterine arteries before they did a myomectomy or a hysterectomy to cut down bleeding at the time of surgery. And there was a physician in Paris about 25 years ago who noticed in the time frame between the women having the embolization or the UFE and them going to surgery, everybody was getting better before the surgery. So he was the first one to publish his experience, but it got everybody's attention, including patients like yourselves, who said, day and age of the internet, second opinions, I know there's something out there and I want to know about it. So it was the patients who sort of brought this to the forefront, and that there were a few of us that had put together a fibroid registry where we had collected, and this is probably over 18 years ago now, had collected data on about 10,000 women, specifics, about clots and bleeding and cramping and pain and the imaging and the procedure and the results. And basically, brought it to the American College of OBGYNs and the insurance companies and said, look, less expensive, shorter recovery time, better results than myomectomy. It's safe. So it's been a long time. We first started doing it, the insurance companies were giving us grief saying it was experimental and they wouldn't pay for it. But I think I'm stealing Monica's thunder because she helps us with authorization and scheduling. Bottom line is the insurance companies have really embraced this technology. A lot of GYNs have embraced the technology, and patients are happy to know that there's a minimally invasive, non-surgical option it's more effective than hormones, but it's not as aggressive as a hysterectomy.
So we do have a few questions here, Dr. Hughes. Let me start off with the Q&A just because there's a few less than in the chat.
Okay.
The first one says, I have a huge fibroid. Can I still become a mom after removal?
Good question. Very good question. Obviously a concerning question for you. I guess it depends how big huge is. There have been women who do get pregnant with fibroids, are able to conceive a healthy baby. So without knowing the specifics in terms of the size and the location, it's hard to know. I mean, if you're somebody who's had miscarriages because this thing is big and bulky and taking up room, and it's one big dominant fibroid, sometimes a myomectomy is a good way to go. I guess without knowing the specifics of your imaging, it's hard for me to give you a specific answer. But there have been women with just a solitary or just one fibroid that we've embolized that have done well and have had successful pregnancies. Now, the pregnancy is, this comes up all the time when we do these webinars. And it's a little bit of a challenging topic or area, because when we first started doing these embolizations, the UFEs, we weren't sure what the results were going to be in terms of, women still having a period, if it was going to put them into menopause, if they'd be able to conceive and to have a baby afterwards. We realized what a safe procedure it was, and we were getting great results. We sort of pushed the envelope in terms of offering it to women who had fibroids and that were told, your only option is a hysterectomy, and they hadn't had children yet. So we worked closely with their OBs and said, all right, let's embolize the fibroids, and let's see what happens. And I think that I've had successful pregnancies in my practice. There have been successful pregnancies, and unfortunately, what I usually tell women is that, there's no guarantee, whether we do an embolization or not. If you have fibroids, there's no guarantee that you're going to get pregnant, but there have been successful pregnancies. And George Spies out of Georgetown, he's an interventional radiologist that actually had the best study that he had published. And this was a number of years ago. And he looked at 3 groups of women one group had fibroids who had a UFE. One group had fibroids who had a myomectomy, and then one group was your control population that had no fibroids, no treatment, and looked at 3 things: placental problems, birth defects, and miscarriages, and that there was no statistically significant difference between the 3 groups. So, were there miscarriages with the UFE? Yes, but it was no higher than the regular population. Were there placental problems or birth defects? Yes, but it was no higher than your average woman who had no fibroids. So, typically what we counsel women is, again, it depends on the anatomy, because there are times too where I've said, hey, myomectomy may be a safer way to go. Just where this thing's positioned or how big it is, it may be a better option. But we have had women, who have had successful pregnancies, healthy pregnancies, and healthy babies after a UFE.
Awesome. Our next comment says, I was told I have a 6-centimeter fibroid and I want to get an endometrial biopsy and possibly get a hysterectomy. My doctor said that I also have high testosterone. I'm not sure if it's supposed to be testosterone or estrogen, but it says testosterone. Do you have any comments on that?
I guess in terms of the hormones, I'd probably have to defer to the gynecologist, because typically we don't work with the hormones, whether it's prescribing them or managing them. And in terms of, I don't know that necessarily a 6-centimeter fibroid would give you an elevated testosterone or an estrogen for that matter, but that's sort of beyond the scope of what I do. But I can tell you from my experience that if you've got a 6-centimeter fibroid, that is not too big for us to embolize. So I think I would certainly consider embolization in terms of your treatment options, because it would be a lot less invasive. And that sort of probably dovetails into as well. I just want to briefly mention, and I could spend 3 hours talking about the procedure and so forth, but the mechanism in terms of how it works, because I think it helps to understand. With surgery, you go in and you cut them out. Either you cut out the uterus or you cut out the fibroids and they're gone. Operation 100% success. Although with myomectomy, up to 1/3 of them can grow back. But with the embolization, what we do is, I had mentioned earlier in the webinar that the fibroids are very vascular. And so that the reason why it works so well for fibroids being vascular is that 3 things happen. Number 1, by cutting off the blood flow, women who are heavy bleeders that clot, who are anemic, the bleeding should improve, that the anemia should correct itself, shouldn't be passing clots, and should still have a period that's a light period. Number 2, by cutting off the blood flow, the fibroids that you have should shrink and that no new ones should grow. The amount of shrinkage is extremely variable. It can be as little as 30 to 40%. It can be as high as 90%. And if you've got multiple fibroids, different fibroids can shrink different amounts. But what's just as important as the shrinkage and controlling the bleeding, and all 3 of these things are what contribute to a successful embolization, is they also get softer. These are smooth muscle tumors because the uterus is a smooth muscle organ. And pathologists have said, when they get a hysterectomy specimen, a fibroid is like a firm rubber ball. And that's why it gives women a lot of problems in terms of cramping, in terms of pain, in terms of pressure, because these things are firm and they're pushing on the bladder, they're pushing on the rectum or the back or the adjacent bowels or the broad ligaments. But after an embolization, when you strip away the blood supply, even though by imaging there's a blob in there, the pathologists have said the blob is more like a little scoop of oatmeal. So as opposed to a rubber ball, versus a little scoop of oatmeal, softer, smaller, no blood flow. And that combination of things gives women the symptomatic relief. So most women are fine with that, that realize that they're still going to be in there by imaging. But if they ain't bothering you and they ain't cancer and they ain't precancerous, most women say, that's fine. I'm avoiding major surgery, your short recovery time, I'm back to work sooner. And if they're in there and they're not bothering me, I can live with that.
Awesome. Our next question says, I had a myomectomy and the fibroids came back a year later. I have no kids at 41 and starting to have issues again with cramps and bleeding. Do I sound like a good case for this new option?
Yeah, I think potentially it could be a good candidate. And I'm sorry that you're having recurrent issues. And, if you've been on the webinar, you're, I guess, one of the gals that I had spoken about earlier saying that with myomectomy, they can grow back. And oftentimes with the myomectomy, the consult that I did, I was almost late for the webinar, but the consult with the gal that I met with just about 2 hours ago, was saying that she had a myomectomy and that they took out one, but she still had 4 in there. And she said, that's great, you took out the one, but I'm still having pain and I'm still bleeding. So I think that, your age is not an issue. I've treated as young as 19, if you can believe it, and as old as 69, if you can believe it, and 4 fibroids. I have women who've been in menopause that they may not be bleeding, but if they're having pain with intercourse, if they're still having back pain, if they're still having pressure on the bladder, the young gal that I had, and the other young gal that I had done, was one of those situations where she had so many fibroids. GYN was saying, we need to do a hysterectomy. And it's like, whoa, she's 19 years old. Let's try the embolization, let her preserve her uterus, and at least she's got a chance to try and get pregnant. So I think you're saying that you're in your early 40s, you had a myomectomy, fibroids are back. And again, I think depending on your anatomy, would have to see the specifics in terms of MR ultrasound. Most certainly, the vast majority of women are candidates for the procedure. So, I think if you're curious or interested, I would suggest, make an appointment and we can go over your specifics and see if it's something that would be useful for you. You women that are on tonight don't know me, but I was saying earlier that, I pride myself, I guess, in being aggressive but appropriate. So if something's the right thing to do, I'm going to, and the patient wants it and needs it, I'm going to make sure that it gets done safely and properly. We can embolize anything. If you can get into a blood vessel, you can embolize anything. The question is, are you going to get relief, or are we going to meet your objectives in terms of what your problems are, and are we going to get you relief so that after we do this procedure, you are a happy, healthy person, and that you don't want anything else done.
Okay. Next question says, I have multiple fibroids. The biggest one is 25 millimeters. If I get this treatment done, can I get pregnant after the embolization?
Again, these are all great questions. And I guess, and I hate to keep saying the same thing to you without looking at the imaging, it's hard to know. Anybody, if you get into a blood vessel, you can embolize any blood vessel. The question is, are you going to get the appropriate response? So 25 millimeters is actually on the smaller side, because that's about 2.5 centimeters. And it depends. What I usually tell women is, you have a uterus, and if you're still having a period and your hormone levels are normal, in theory, you should be able to get pregnant. But we cannot promise future fertility, even if we didn't do anything. Unfortunately, the fact that you have fibroids, can be challenging and problematic in terms of getting pregnant and maintaining a pregnancy. But it doesn't mean that it's not possible. And then the beauty of this procedure too, because you had mentioned you had multiple fibroids, is with this procedure, we're not going after each individual fibroid to embolize it and to plug it up. What we target, and that's why the MRI is so important ahead of time, is the MRI shows us the size, the number, the location, and the vascularity. And then that helps us determine how safe we think this is, how effective we think this is. Whereas on the day of the procedure, we don't see the individual fibroids, but what we target is the abnormal blood flow. And we don't have to go after each individual little fibroid. I mean, I've had someone where there are 50 fibroids, and you don't go in after each little fibroid, but you target the abnormal blood flow. And so what's nice about this is, by embolizing, it's one approach. We go through the right groin, which I can talk about that a little bit more. But by going into the one groin with a little Band-Aid afterwards, we're able to get into both. All the plumbing is connected. We're able to get into both the right and the left uterine arteries, and that we can plug them up or embolize them. So it's nice that, we're not having to go after each individual little fibroid. So I think that again, without seeing the imaging, what I can tell you is if you still have a uterus and a period and normal hormone levels, in theory, fertility or getting pregnant in the future should be feasible.
Our next comment says, I had a myomectomy and my fallopian tube had to be repaired. I haven't gotten pregnant since and they've grown back. If I had them removed before and they came back, what does that mean?
Well, unfortunately, it means you're one of the women that I had talked about that's saying, anywhere from a third to a half of women who have a myomectomy, their fibroids can grow back. So not that it's dangerous, not that it means it's cancer. It just means, unfortunately, your fibroids grew back. So again, if they're not bothering you, you don't need to do anything in terms of treating them. But if you are suffering from symptoms with heavy periods or clots or anemia or pain or bloating or urinary symptoms, you're entitled to think about treatment. And for us with the embolization, it doesn't matter if you've had a previous myomectomy. Now, in terms of the fallopian tube, I guess if you're trying to get pregnant, typically, or trying to get pregnant and having issues, oftentimes your OBGYN will order what's called a hysterosalpingogram, where that's a test that the radiologists do, where you put a little bit of dye into the under X-ray into the uterine cavity, inject dye to see if the tubes are blocked or if they're open. So even though they took one tube, you still have one tube. And if you got a healthy ovary on that side and an open tube, in theory, you should still be able to get pregnant, even with only one tube.
What are the side effects of this procedure?
I guess I wouldn't necessarily say side effects. With the procedure itself, typically after the procedure for recovery time, I usually tell women to take 2 weeks off from work, which obviously is a lot shorter than after a hysterectomy. I've had some women back to work in 3 or 4 days. Some women have needed the full 2 weeks, but the average is usually about 7-8 days of recovery. And what the recovery entails is you're crampy and you're bloated after we do the procedure, because we've got some pissed off fibroids that in a matter of minutes, we inject these little gelatin beads, which are FDA approved. And by cutting off the blood flow, you've got fibroids that are going to cause contractions and cramping. So that we send women home on a prescription of ibuprofen. And if they have allergies, we have other medications. But basically, the beads are important to cut off the blood flow. The ibuprofen is important afterwards as a non-steroidal anti-inflammatory to help with the cramps and the inflammation and the recovery process. So that's basically what to expect after the embolization. Now, probably the more important question, I guess, not so much side effects, is what would be the complications or the risks that are associated with it. And again, it's a very safe procedure. It's done under twilight sedation. There are several that I usually like women to be aware of that, again, are few and far between. But obviously, anytime you touch a patient, even to have your blood drawn, there are risks and complications. So first and foremost is obviously anytime you touch a patient, whether it's a root canal, a boob job, a C-section, an aneurysm repair, having a baby, having your gallbladder taken out, there's always a risk of infection. And there have been reports of infection requiring hysterectomy, but extremely, extremely rare. And it's mostly the European data where they don't give antibiotics when they embolize. And here in the United States, we give an IV antibiotic during the procedure, and then women go home on an antibiotic by a pill for a couple of days afterwards. And taking care of some sick women, liver transplants, kidney transplants, diabetics, morbidly obese women, and we've not had any issues in terms of infection. So very touching you. Second is that there is, I guess, depending on your age, anywhere from a 0.5 to about a 2% chance of going into to menopause. I've done over 1,000 embolizations, and I'm at less than 0.5%. I have had a couple of women who've gone into menopause, but they were all in their mid 50s and already starting to go through the change. So in theory, but typically, like I said, it's less than 1% chance. And if that does happen, obviously that's an issue in terms of women who potentially want to get pregnant in the future. But If you're not looking to get pregnant, it's not going to cause cancer, gangrene. You don't have to have the ovaries taken out. You don't even have to go on hormone replacement. It's only if you're having symptoms that you and your GYN would decide hormone replacement or not. So, infection, obviously we're touching you. Risk of menopause. Third is, vascular damage. We're touching a blood vessel, and there's the potential for us to damage the blood vessels. But again, this is what we do as vascular radiologists. So, we put in carotid stents, we embolize aneurysms, we repair belly aneurysms, we pull clots out of the blood vessels in people's lungs. We balloon and stent plaques and blockages in the legs. So this is what we do for a living, and that typically our fibroid patients, our population, are young, otherwise healthy women with healthy blood vessels. So again, it's in theory touching you, but I think for the most part it's a safe procedure. We use X-ray dye for us to get the roadmap and see what we're doing. Once in a blue moon, somebody may have a reaction to that, but again, unusual, and typically it's a hive, or it's a little itchy, and we're able to control it with steroids. So an embolization in the hands of somebody who knows their anatomy and knows how to embolize is an extremely safe and effective procedure, whether it's for fibroids or anything else.
Would you consider it a painful procedure?
The procedure itself is not painful because we do it under a twilight sedation, so that women are very comfortable during the procedure. And I've been doing this, like I said, over 20 years, and I'm in menopause now, but I had many years of painful periods, so I know what it is to have bad cramps and to suffer from bad cramps. So that and I'm my specialty is predominantly male. I know when I first started, I think only 4% of us are women, so I think that's part of the reason I've sort of embraced this procedure, and I've sort of been a role model in our community, having written books and taught other physicians how to do it, because it's something that I know what it is. For a guy to say, big deal, it's a cramp. No, it's a big deal to have a cramp. So I think that the procedure itself is not painful. The recovery time, I usually tell women, to expect, cramping like a bad period for the first week, and each day it's a little bit better than the day before, but I've got a nice cocktail worked out between ibuprofen and a few other things, heating pads, that we're able to get women through that first week.
Awesome. So our next comment says, I did my UFE procedure a month ago. I lost 15 pounds and feel great. I started seeing results immediately. My question is, I have spotting for a month now, but I'm not sure what my period should be like now.
Wow, that is first of all, you should be a poster child for us. But second of all, that's a great question, and kudos for you for coming on the webinar. You've already had it done, to be able to share your experience. So I think that I'm glad 15 pounds. Wow, I'm impressed. I'm impressed. Good for you. I'm glad you feel great. What I usually tell women when I do the consult is that the recovery time, is I say, 2 weeks off from work, recovery about 7, 8, 9, 10 days in terms of the cramping getting better. I usually tell women that it's not like we take a balloon and you stick a pin in it and you pop it and immediately you're going to feel better. But it's a situation where we've cut off the blood flow. And initially you've got some pissed off fibroids. They're ischemic, they're infarcting, and before they shrink and retract into the wall, it's uncomfortable. So that's why there's the cramping the first couple of weeks. So I usually tell women that even though you'll notice, I would say from my experience, 90% of women within the first month will notice a difference in terms of their symptoms, especially if they're a heavy bleeder. But 10% of women, it can take 2 to 3 cycles or months for it to kick in. Because initially there's inflammation, which is why the ibuprofen helps, but then they're going to shrink. So, and again, I hate to be gross, but like the 10%, say we did this 3 days before your period, and you're one that's a heavy bleeder and you pass clots, you've already built up that lining and you have to get rid of it. So the first month may still be heavy, but the second month should be better. Even though, you're feeling better within the first 2 to 3 months, these fibroids are going to continue to shrink and infarct and involute and scar down for up to a year. The maximum shrinkage is 10 to 12 months later. Now, your question about the spotting is I usually tell women the first couple of months, anything goes. You can get your period right on time, and it can be a light first period. You can get your period on time, and it could be the same period from hell that you've had. Because like I said, you've already built up the lining and you got to pass the clots to see the effects. You may get your period early. You may get your period late. You might have some spotting, some little stringy or mucousy discharge. Again, I don't know the specifics of your embolization, but sometimes if there's a little bit of it that pooches into the cavity, you can have some sloughing or discharge. But sometimes too, the contractions and the cramping, can be severe enough after the embolization that you might have some spotting that isn't your typical period. So I usually tell women first, 1 to 2 months, keep a little light pad, a little light liner, or, one of those light days, keep it handy, keep it in your purse, keep it in your bag, keep it in your wallet, or your locker at work, because you might have a little bit of spotting or discharge. And that is not dangerous. That is not abnormal. As long as you're not having fevers, as long as it's not smelly, as long as it doesn't look like pus, but a little bit of discharge is not unusual at all. But congratulations, good for you.
Our next comment says, I have a large 15 centimeter and several smaller fibroids. How much shrinking can I expect? Are they likely to shrink enough to be removed vaginally versus being cut from under my ribs to my pelvic area? I'm not interested in getting pregnant.
Well, these are some great questions tonight. 15 centimeters is big. That is a big fibroid. And even if we were to do an embolization and for it to get softer and smaller and there to be some shrinkage, if I were a betting person, it probably would not shrink enough for them to remove it vaginally. I have a feeling that unfortunately it would still have to be an open, as you said, it would have to be a traditional surgical exposure and not vaginal, or I mean, it's possible they might be able to do it laparoscopically, but that's pretty big. The shrinkage we can't guarantee. Like I said, on the low end, it could be 30%. On the high end, it could be 90%. And different fibroids can shrink different amounts. And we've got no magical ball, to know which way, how much these things are going to shrink. I mean, probably what I would suggest if you're not interested in getting pregnant, and you are having symptoms from this, is I would suggest the embolization, because I guess if you want to do something, and you don't do an embolization, it's going to have to be open surgery. If you do the embolization and you're not satisfied with the results, you could have the surgery, but there's a good chance you could do the embolization and be done. That's all you'd need, because you're not going to be looking at the follow-up imaging saying, gee, it only shrank from 15 to 11. I mean, what's important is, how are you feeling? Because if it's not cancer, it's not precancerous. And if it's in there and it's not bothering you, it doesn't matter how big it is. I mean, and that sort of reminds me of, I have a woman, she was, gosh, I probably did her close to 20 years ago now. She was a gal from Palm Beach, I remember. And she had a 120 centimeter fibroid. And, I looked at this thing and it's like, whew, this is when we first started doing them. And I was like, oh, that's too big. I mean, I can embolize it, but you're not going to be happy with me. You're going to be awfully crampy and miserable. And I don't know that you're going to get the results that you're looking for. And she's like, well, I'm not having surgery. I'm like, well, I don't know that this is the right thing to do. It's not dangerous, but I don't know if you're going to get the relief that you want. She's like, well, I'm not having surgery. It's not an option. I'm not doing it. Her GYN was somebody that I have been working closely with for several years. I called her and said, hey, I think you should talk her into the hysterectomy. And she's like, well, let's do it. And this is when we first started doing it, like 20 years ago, in our learning curve in terms of who do you treat and who do you don't treat and how much do you push the envelope. And I said, well, I'm willing to do it as long as both you, the GYN, and the patient understand, for whatever reason, she's miserable afterwards, you don't get the relief that you want, or there's any kind of a problem embolizing something this big, you both agree that you're going to take her to surgery. And they're like, yep, fine. Fine. So we did the embolization. Technically, everything went well. And she shrank from 20, the fibroid shrank from 20 to 14, which is still huge. And I think a lot of you women that are on this webinar tonight, like, wow, 14, that's still massive. And I was like, wow, that thing's still big. And she was as happy as a clam. And it's funny that I say that, I mean, no pun intended. She had worked for like the water parks and recreation, that she has something to do with clams. And she's like, I'm out in the water, in the Everglades for hours. There's no bathroom out there. I'm peeing all the time. But she just said, she said, my symptoms have gone away. I don't care if it's 14 centimeters. It's not bothering me. I'm not peeing. I have no pain. I have no back pain. I have no cramping. She said, I'm done. I'm happy. So that was, that was a lesson for me. but it is big. So again, without knowing sort of more of the nuances of your particular medical history, are there other fibroids? How big are they? Because there are times where I'll say, gee, hysterectomy may be the way to go, or myomectomy may be the way to go. But, and again, I'm biased because I do the procedure. But I think the vast majority of women I have seen have been good, safe, and appropriate candidates for the UFE.
What if the fibroid is outside of the uterus? Is the artery still able to be blocked? I've heard that you could experience extreme pain as the fibroids die. Is this so?
Again, we're getting some good questions. In terms of the fibroid outside the uterus, again, I hate to keep going back to being a radiologist and I have to see the films, but I have to see the films because fibroids start in the wall of the uterus and most of them grow and bulge, stay within the wall, and they grow and bulge and distort the wall. There are some that can pooch into the cavity, what we call submucosal, and there are some that can bulge out. They're called subserosal. Some of them just bulge out, and that they've got a broad base and a broad attachment, almost like a mushroom. That is safe and appropriate because it's still the blood supply coming from the uterine artery. If it's what we call pedunculated, which is on a stalk that's like a lollipop, those technically, again, we can embolize them, but usually decline those because, again, we have learned along the way. Scott Goodwin, who was out at UCLA, and he was one of the pioneers with this UFE procedure, learning in terms of who can you treat and who can you not treat and what's safe and what's not safe, is he had somebody that had a lollipop, had a pedunculated fibroid, did the embolization, but what happened was that little stalk, the cardboard lollipop part, that became ischemic because it didn't have the blood supply, and then since that was so frail and thin, it snapped off, and a woman's fibroid was rolling around in her belly and causing peritonitis and pain. So we know pedunculated fibroids, which again, you get a good three-dimensional look with them are. If it's a pedunculated on a thin stalk that's growing out of the uterus, it's not appropriate to embolize. Although that being said, again, it depends on the individual. I had a gal, I remember now, I forget how many years ago this was, but she was young, future fertility or getting pregnant was an issue. And she had one pedunculated fibroid that was in the front of her uterus. And what the OBGYN and I did was I embolized it. And then she did the myomectomy like the next day. So that, we were able to minimize bleeding, by devascularizing the fibroid. And then she resected that one that was on the stalk, which made it a safer surgery for her. So I hope that answered the question.
What is the recovery time for the ablation?
Actually, it's an embolization. An ablation is where you take a probe or a balloon and you burn or freeze something. But this is an embolization where we're putting something, gelatin beads into the blood vessels to cut off the blood flow. The recovery time I mentioned earlier is anywhere from, I usually tell women take 2 weeks off from work. I've had women back to work in 3 days. I've had women that needed the full 2 weeks, but the average is usually about a week, good 7-8 days. And just you're crampy, you're bloated. It's like a bad period, but each day you feel a little bit better than the day before.
My gynecologist does not recommend this procedure. How come?
That's a good question. I guess there's several ways to answer it. I guess I used to say when it was new, it's because it was new and the gynecologists weren't familiar with this as a standalone treatment for fibroids, but it's been around long enough that any gynecologist today should know what a UFE is and should offer it to patients as an option if you're talking about treatment options for fibroids. There are situations, though, where it's not appropriate, few and far between, to do an embolization. So, and again, I typically work in conjunction with the gynecologist. Sometimes if women have significant health issues, is work with, their primary care, just to make sure that, we're taking care of the patient safely. But yeah, it's a little disappointing that some of the gynecologists are not not recommending, or even just telling a woman, you know, just look at your options and let's help you make a decision. So I think that, you know, if you think you potentially are a candidate, and what I'm telling women too is if women have found me through webinars and things like this, you know, friends, primary cares have sent them in. And if somebody's a candidate and the gynecologist isn't on board or supportive, is I work with enough GYNs in the area, we just find the patient a new gynecologist. Because that's a little troubling that if you're a candidate for something and they're not willing to recommend it, you know, do they really have your best interest at heart? So again, several reasons. You don't know about it, shame on you. It's been around long enough, you should know about it. Or, you know, you'd rather perform surgery on your patient than to give them a non-surgical option. So anyway, I'm being honest here.
What would you recommend for a patient that not only has fibroids, but they have endometriosis or pelvic congestion or cysts and polyps?
Yeah, I think, you know, that thank goodness it's the vast minority of women, but, you know, occasionally you do get women who have multiple things going on, and it's trying to tease out and sort out, as you said, you know, you mentioned pelvic congestion, which is a venous issue. You know, you mentioned ovarian cysts, which are, you know, little water pockets on the ovaries that can cause pain. You know, endometriosis is another animal that, you know, women can have pain from that as well. So I think it's important, you know, to get a good history and good imaging and a good physical exam and try and tease out, you know, is one thing responsible, or is it a combination of things? And then just try and figure out, okay, what do we think is the primary problem and attack that first. But you also sort of bring up a good point too, is endometriosis. So basically we had said earlier in terms of talking about the anatomy that the wall of the uterus is smooth muscle where the fibroids are born, so to speak. There's a glandular lining inside the cavity that's called the endometrium. And every month with our changes in hormones, that gets thicker. We anticipate we're going to get pregnant. We don't get pregnant, you slough it off, and that's what our period is. So endometriosis is, for whatever reason, women can have little tiny implants of that glandular endometrium outside of the uterus. It could be sitting on top of the bladder, on top of the bowel. It could be stuck on the pelvic wall. And every month with the hormonal changes, those little implants get engorged and they bleed and they cause pain. So the embolization doesn't work for that because it's outside of the uterus and you can't identify a safe enough blood supply to embolize. And typically, again, I defer to the gynecologist if it's surgical, if it's hormonal, in terms of how to treat that. But there's a variant of endometriosis called adenomyosis, adenomyosis, adenomyosis. And basically what that is an endometriosis of the uterus. So that glandular lining inside the cavity, like little fingers, grows into the wall of the uterus. And again, every month with the changes in hormones, it gets engorged in the wall, and it causes pain. The UFE, or the uterine artery embolization, actually is a great treatment for that as well. Because I've seen women with fibroids alone, women with both fibroids and what we call adeno, or women with just pure adeno. And as long as we have the imaging by MR to confirm that that's what it is, and it shows that there's a blood supply, by cutting off the blood supply, those little glandular implants shrink and scar down, and it alleviates the problem. So endometriosis outside can't help it. But again, you get back to, is it the cyst? Is it pelvic congestion? You know, is it fibroids? Is it the endometriosis? Is got to tease out, all right, what are your symptoms? What brings it on? What makes it better? What makes it worse? And then try and decide, okay, what do we think is the primary problem?
Would you say that there is a lot of pain as the fibroids begin to die off after the procedure?
Everybody's different. I used to tell women, expect it's cramping like a bad period, and that we're able to control it. During the procedure, we use an IV form of ibuprofen because that actually blocks the contractions and the cramping. And then going home, it's a prescription dose of ibuprofen with some Percocet for breakthrough cramping. But women say it's like a bad period. Like I said, each day it's a little bit better than the day before, and that there are some women who can't take ibuprofen or have a problem with Percocet, and we have alternative medications that we prescribe and work with them. So heating pad and usually ibuprofen are a girl's best friend for a week after the embolization.
Okay, I do believe that that is most of our questions. Ladies, if you do have any more questions, please drop them now. We're going to give them a couple more minutes. Would you need a referral from your gyno to do this procedure?
Actually, Monica, you could probably answer that better than me.
Yeah, I definitely can. Okay, so honestly, it may not always be necessary from your gynecologist. We definitely will take all of the documents that are provided from your gyno visit. It really depends on what your insurance plan is, whether it's an HMO or a PPO. I forget which one requires a referral, and even then, the referral would be provided from your primary care physician, not your gynecologist. But if you leave your name and your phone number in the chat or in the Q&A, I'll give you a call tomorrow. As long as you have your insurance card, I'll need that, and your date of birth. I'll be able to look up your plan and let you know.
Okay, great. Great. Yeah, so I'm glad that ladies were able to join us this evening. We all have busy work schedules, but this is important information to try and get out to gals like you, because it's a really good procedure. I've been pleased with the results. I've had some very happy patients, and for it to be so minimally invasive and short recovery time and some really good results. So it's a good option at this point until we can figure out what causes them and stop them from forming. This is the best we can do on the back end in terms of trying to at least treat them and avoid surgery.
So one of the next questions is, what if you don't have insurance? I can go over all of your options with you tomorrow. If you already left your phone number for me, either in the Q&A or in the chat, I'll be reaching out to you tomorrow. If you haven't already, please leave it, just so that I can discuss with you. And I'll let you know what all of your options are. If you plan on applying for insurance, I can let you know which insurance plans we are taking, so that you know what your options are. And then if you can't apply for insurance, there's different options like care credit, which I can go over with you tomorrow.
Any more questions coming through, Monica?
No, I don't see any new ones, but I am currently scrolling through the chat just to make sure I didn't miss any.
Okay.
I did miss one. One of them says, does steaming help shrink and possibly help with them disappearing?
Steaming. I guess I'm not sure what that means, as in, getting into a sauna or steam room. I guess I haven't heard of that as an option. It may give you some symptomatic relief, but it's not going to do anything to help with the bleeding if those are your problems, or it's not going to do anything to shrink them. So, if it helps in terms of, like I said, cramping, back pain, those kind of symptoms, that's great. But it's as far as I'm aware, it's not an effective treatment by itself.
And one of the last Q&A questions, I think you did go over it, but there are 4 different types of fibroids, and even I get confused sometimes. It says, what about the intramural fibroid? Can the UFE still work? Does the UFE work for all 4 kinds?
I guess the short answer is yes. and then the long answer is it depends. So intramural is in the wall. That's where they all start, and those are the best ones to treat that are intramural in the wall. So an intramural fibroid is perfect. If you have a subserosal one, which is one that's that's bulging out, it depends how much of a stalk, how thin or long the stalk is. If it's got a broad base, that's fine. If you've got a submucosal one that's kind of pooching into the cavity, again, it depends if it's on a stalk. It depends how big it is. So whether it's subserosal, submucosal, intramural, pedunculated, most of those, I mean, technically they can all be embolized, but most of those are still safe to embolize, but there are some outliers, like I said, a thin stalk or how big it may be protruding to the cavity that may be a problem. But that's something looking at the individual's imaging to say, appropriate or not appropriate.
So there is one last question, but I think it's more for me than it is for you. It says, I have Bright Health Insurance. If you can call after 2 p.m., please. After the procedure, does the patient stay overnight in the hospital? So we are not in network with Bright Health yet, I hope. I know that we're in the process of dealing with new insurances. We don't necessarily have an exact date or know when things are going to be finalized. I know that paperwork has been submitted, but I guess right now it's just a waiting game. I can definitely call you after 2 p.m. so we can go a little bit more over all these details. And as far as an overnight, so it's not a hospital, it's an outpatient clinic. And this is not an overnight stay. You come in after doing all of your consultations, follow-ups, blood works, imaging. If you are scheduled for this procedure, you will be scheduled for 8 a.m. The procedure takes anywhere between 20 minutes to an hour, really depends on the person and on their case. They keep you at the center for a 3 to 4 hour recovery and observation, but you do get to go home the same day.
Yeah, few and far between that I've had patients within the last 5 years that have had to be done in the hospital or to stay overnight in the hospital. And there've been sort of outlying situations with women having other complex medical issues, just that, one gal that was, 450 pounds, somebody else with muscular dystrophy that had a lot of contractions that we needed anesthesia to help relax them so we could get access, protect their airway. But I mean, like I said, it's as Monica said, typically we do this in our outpatient center and you go home the same day. Come in the morning, you go home in the afternoon.
All right. Well, Dr. Hughes, I know it's 7. Thank you for taking the time. I'll leave it open for just one more minute.
Okay. Yeah. Well, thank everybody for taking the time. Appreciate it.
Absolutely.